The next speaker is Head of National Center for Tropical Infectious Diseases at Haukeland University Hospital and Associate Professor at the University of Bergen. Kristine Mørch, welcome to the Letten Seminar.
Thank you. Thank you for inviting me to talk about malaria in India. Yes, it's an honor. Thank you so much. So, I would not have known much about malaria in India if it wasn't for my friends and colleagues in Christian Medical College in Vellore in India. It's a large university hospital in Tamil Nadu, one of the best hospitals in India. And to the right here in the picture is Dr. Dilip Matai, who is the principal investigator of the study I'm going to tell you about, and who I met for the first time almost 20 years ago when we started our collaboration with Christian Medical College. We are so fortunate to have that. And we still run a course in tropical medicine every year at CMC, and we've done a fever study together that I will tell you about. And to the left is Dr. Anil Henry, who is from one of the 7 hospitals in the study. It's a very small hospital in Mungeli in Chhattisgarh, one of the poorest states in India. No studies have been done on malaria in secondary hospitals there before. It's very little studied. He's a surgeon, but sometimes he's the only doctor in the hospital, so he's treated more fever patients than any internal medicine specialist. So I'm so grateful to know these people. And I would not have been able to ask research questions without knowing them. So how much malaria is there in India? It's a very good question, and rather than showing you maps of very uncertain numbers, I show you this map of the mosquitoes. There are more than 40 Anopheles species in the world. We also have one in Norway, not very effective. But in India, they have very effective Anopheles species, Anopheles fluviatilis, for instance. Similar efficacy as Anopheles gambia in Africa, very effective. And the prevalence depends on if the vector is there and socioeconomic conditions. And do we know if people die from malaria in India today? So these are numbers from reported numbers of cases and deaths in India for 10 years up to the pandemic. Less than 1,000 deaths reported every year. And it's been like that for more than 30 years. Less than 1,000 deaths have been reported every year from the Indian health authorities. The National Vector-Borne Disease Control Program in India report their numbers to WHO. So these numbers are published both at WHO yearly reports and, of course, the national numbers. Approximately 1.5 million cases. These are microscopy or rapid test confirmed cases that's been reported. Yeah. So, well, this is a picture from the door outside National Vector-Borne Disease Control Program, actually, in New Delhi. And do reported numbers reflect the correct incidence? No, not at all. And it's very frustrating, actually, because when you show this number in a report, it's interpreted as if there has to be some element of truth in it. So why report it at all when it's so just incredibly wrong? And I will come back to that. Because the population in India is more than 1 billion people, and 70% live in rural areas in poverty with very little access to diagnostics and treatment. So we had to walk for 2 hours through the wood to get to this village, and people there had not seen a doctor. So malaria in people without access to health care, they are not detected and not reported. It's as easy as that. But what's maybe more difficult to understand is that so many, they don't have this access in India, still in India. Maybe 70% of the population live in very poor areas with no access to treatment. So reported numbers based on diagnosed cases, they say nothing about the true incidence in poor communities in India. But WHO, they also report estimated numbers. Are these more correct? So in 2019, they reported 4 million cases in India and 7,300 deaths. It's 1.3 billion people in the country. So in 2010, Lancet published a verbal autopsy fever study that was very much discussed. A verbal autopsy study means that they asked people in rural areas which symptoms their relatives who had died had had. So it's very unsure and unspecific, of course, but based on that, it was found that 26,000 had died from malaria, and 86% of these had not had any access to healthcare facilities. And if you estimate based on that number, then total malaria deaths would be between 125,000 and 277,000 per year. Not 1,000 and not 7,300 either. But the study has been very criticized and discussed, of course, because a verbal autopsy study is very uncertain. But it was very much discussed also in the media. And the media in India is very critical, can be very, it is a democracy, so it's very critical. And like it says here, the malaria crisis in India, it's been revealed from this study that the malaria crisis India doesn't want to acknowledge. And it points on the inequality and the insufficiency in the government hospitals. So the background from the fever study that we did was that CMC, they have a network of mission hospitals all over India, very well-functioning small hospitals in poor communities. And in Tezpur in Assam, in North India, there is a small 130-bed hospital. And the clinicians there came to Dr. Dilip and said, we had 167 malaria deaths this year. That's close to the total number reported in India. Why is that? Can it be that malaria is very much underdiagnosed in secondary hospitals in India? So we started a multi-center observational study of malaria in patients with acute and differentiated fever in India. It was done in 2011 and 12. And these small hospitals were situated in 6 different states in India, so all over India. And it was monitored from CMC in Vellore in Tamil Nadu. So they were the size from 100 to 500 bed hospitals. And it was part of a clinical fever study with 1,564 patients of children and with fever for up to two weeks. And a routine diagnostic, it was an observational study, so routine diagnostics tests were performed at sites: malaria, microscopy, blood culture, IgM ELISA test for various diseases, and we did confirmatory gold standard analysis at the reference lab. And tests were provided to the hospital for the sake of the study. They did not have any blood culture facilities, but that was provided, and also these ELISA tests. And again, this is a picture from Mungeli Hospital, which is a typical malaria high endemic state. It's close to Orissa, which is very much studied. Many malaria studies have been performed there. And this is from Ambur in Tamil Nadu, a typical malaria low endemic hospital. So, yeah. And the design for identifying malaria in the study was that, like I said, microscopy was done at site, thin and thick slide, and technicians were trained at CMC and also with the quality control slides sent to CMC during the study. And PCR was performed at the reference lab. We did the pan-malaria PCR targeting mitochondrial DNA, which is a very sensitive PCR. It will detect like 100 times more than microscopy. Very sensitive. And we did species-specific PCR targeting 18S of falciparum, vivax, and malaria. And if it was negative, we did sequencing. And rapid tests were also performed at the lab. So, how much malaria did we find in fever patients in small rural hospitals? 19% of the patients had positive PCR. 54% falciparum and 46% vivax. And this was the most common cause of fever in the study. We found a lot of cross-reactivity as well, but malaria PCR was more common than dengue and leptospirosis and bacteremia. And so that was surprising, actually. And the distribution was what is already known, that is that there's a lot of malaria in central India, so we found that. But also like in Maharashtra, in West India, it's not been, the maps will not show you a lot of malaria there, but that was the highest prevalence, 35%. And falciparum, in India, there will be approximately 50-50 falciparum and vivax. And we did find, not very surprisingly, a little less falciparum in the south and more in north and central India. And case fertility was fortunately not higher than 2.7%. 7 patients died. And this is because they came to hospital, of course. Because people who die, they never come to hospital. And these small hospitals are very well functioning and people receive treatment. And we did study that as well, that 16% of the fever patients, they had received antimalarial treatment. 76% of the microscopy positives and only 15% of the microscopy negatives, showing that it's targeted treatment because they did have microscopy as a diagnostic test. Different from septicemia, where you would give everybody antibiotics, of course, because that's a differential diagnosis. And all who died from malaria had received effective malaria treatment, so that's good, but why did they die? Probably because they arrived late, which is typical, but we also showed that and published that. It has to be said. People who had severe organ failure at admittance, like bleedings and cerebral dysfunction, respiratory failure, oliguria, as a sign of delayed hospitalization, had a high risk of death in the study. And what about routine diagnostics? Not very sensitive. Rapid test 24% and microscopy 29% compared to PCR. And that's not surprising either. We know that PCR is very much more sensitive. But what is not very much described in India is that submicroscopic malaria is very common. And this year a meta-analysis was published where our study was included in that one, showing that submicroscopic malaria was found in approximately 10%, both in fever studies and in community studies. So this is well known from Africa. People control a low-level parasitemia with their immunity, And this is the source of malaria transmission. So it's a problem. And the pool prevalence in India, no, I said wrong, is 3.6%, but from less than 1 to 38%, which means that people with no symptoms, they do have malaria parasites in their blood. Yes, so I want to thank the study group in India and in Bergen, and thank you for your attention.
Thank you. Thank you, Kristine. It was very interesting. I have family in Uganda, so I was also very interested in this thing about how people always say stuff like, oh, you know, we didn't have much COVID here. And I'm like, based on what?
Yes.
When you have 70% of people living in villages with very little access to healthcare, how do you trust these numbers?
Yes, thank you for commenting on that. Thank you for taking that point. Yes.
Yeah, so I think this is a problem in a lot of places.
Yeah, we like numbers.
Yes.
We trust numbers. It makes us feel safe. We want to see numbers.
Yes.